This episode of the Senior Rehab Podcast is sponsored by the Academy of Geriatric Physical Therapy. AGPT's mission is to further your ability to provide best practice physical therapy and to advocate for optimal aging. How do they do this? Well, one way is by connecting like-minded individuals around a specific topic. We call these special interest groups, or SIGs. One SIG is a health promotion and wellness special interest group. I highly encourage y'all to check out some of the work they've done, especially with their presentation on physical activity, a key to successful aging. You can access this presentation for free and learn about how the AGPT can further your clinical practice at geriatricspt.org/SRP. Hit me!
This is a Senior Rehab Podcast, the podcast for rehab clinicians that want to better serve older adults.
Hey there, Senior Rehab Podcast listeners. This is Erin Carey.
And I'm Tali Spaceman.
And you're listening to SR Prereqs, the evidence-based portion of the Senior Rehab Podcast.
So, Erin, do you give your patients instructions?
Like in general?
In general.
All the time.
Yeah, it's a pretty crucial part of our job.
Yeah, I mean, I don't know how else they're supposed to do the things that they do.
Did you ever think if our patients understand your instructions?
I try and check their comprehension by asking them to repeat it to me or having them demonstrate what I want of them. But, I mean, in lieu of that, no.
Okay. So it's not a problem that only us physical therapists have. Mm-hmm. Discharge instructions communicate important medical information that helps patients manage their own care, especially when they leave the hospital and we don't see them anymore.
Yes.
Hopefully we don't see them anymore and there's no readmission, because that sucks.
Frequent flyers, man. My life is all about that.
My life is all about that. We have one patient is I don't know if you came from theater as well, right?
Yeah. Oh, yeah.
So we're not allowed to say her name because it's like saying her name like Macbeth. Like it's like she will come back if you say her name.
Oh, man, I probably have 4 or 5 people like that in my hospital. I'm going to make that joke now, and my colleagues are going to love it.
Oh, you're going to still make joke?
I'm going to give you credit.
I love you.
Be like, my friend Tali, she said Macbeth.
Yeah. The patients do not always understand these instructions.
Shocker.
Yeah. And I'm not talking only about physical therapy and exercise, but also about nutrition and, most important, medications.
Yeah.
And should I go to see a doctor again or no? And all of those. So non-comprehension of the discharge instructions is associated with decreased compliance because they don't understand, so they cannot comply with what they do not understand.
Also a shocker.
Yeah. And that could lead to poor health outcomes.
Shocker.
So the article I'm going to talk about, it's called Hospital Discharge Instructions, Comprehension, and Compliance Among Older Adults.
This is so cool. I was thinking about this. I tend to just kind of pick whatever articles I come across. You seem to find quality articles.
I have ADD and dyslexia. It's really hard for me to read, so I'm not going to read something that I'm not interested in.
Yeah, but you pick really interesting things, that I also find interesting. Can you just find my articles and make my life... All right, listeners, you're going to hear about weird stuff.
This was published in 2014 in Journal of General Internal Medicine. It's a prospective cohort study.
Okay.
The objective of this study was to quantify the prevalence of non-comprehension and non-compliance with discharge instructions and to identify associated patient characteristics.
I'm very interested in the outcome measures for this. Because I don't know, I hear things that people want to measure and I'm just like, how?
So, and you're going to hear about how they measured it. Let's start with the population before we go to the measurements. They conducted a prospective cohort study of a community dwelling adults age 65 and older that were admitted to general medical and surgical services of the University of Maryland Medicine Center. They were all admitted between July 1st of 2011 and August 9th, 2012. It's a year and a month. It's a 757-bed tertiary care hospital in Baltimore, Maryland.
Big.
Yeah, it's a huge hospital.
Yeah.
Well, they have more space.
Yeah. Oh, New York City.
New York. eligible patients were enrolled in their hospital rooms within 72 hours of hospital admission.
And it was just everyone over 65?
So they started with everyone over 65. I'll go to the exclusion criteria later.
Cool.
But it's very important. They enrolled in the first 72 hours to their admission and followed up with a telephone call 5 days post-hospital discharge.
Oh, I'm curious about the rates of like compliance, and
it would be like
I know we'll get to it.
We'll get to it.
I could just imagine myself like if I were admitted to a hospital at the time, I'd be like, sure, whatever, I'll do a study, and then 5 days later, I'm like, I'm doing stuff. Go away.
I'm recuperating. 3,492 were eligible.
Nice.
From that, 2,742 did not participate or refused.
Not nice. Wow.
Okay. And from that, we're left with 750 participants that consented and enrolled.
Okay. That's still respectable.
Yeah. And out of that, after 5 days, 105, either they didn't contact them, they couldn't reach them, or they said they do not want to participate, or they died. And they excluded patients that were admitted to psychiatric, obstetrical, and intensive care units.
Oh, okay. So, all right. I like this. Okay.
Yeah. And people that reside in nursing homes.
Yeah, that makes sense because they want to look at the community dwelling population.
And people that are unable to communicate in English or with mini-mental state examination, the MMSE score of less than 15.
So like cognition within normal limits.
Yeah.
Nice. I like it.
Thank you.
You're welcome. You did this study.
No, I chose it.
You did. So far, so good.
Baseline.
Okay.
So what did they measure at baseline? They gave them a baseline questionnaire.
Okay.
Again, in the first 72 hours. Why it's important that it's the first 72 hours, the selection was with the least bias that way. So they asked about the demographic information, depressive symptoms. They were using the 5-item geriatric depression scale,
nice.
GDS, and defined clinical important depressive symptoms as a score of 6 and greater. Because that's the cutoff point that most research uses. It has a sensitivity of 83%, specificity of 69%.
All right.
Disability was measured with Katz's activity of daily living.
Yeah.
There's a range of 0 to 5. 0 indicates a higher function. Cognitive impairment, they used the mini-mental state examination.
Okay.
0 to 30. And social isolation with the 6-item Lubin social network scale, LSNS6.
This sounds like a fun scale.
It is, and baseline interviews were conducted by 2 trained interviewers. Other data that was collected from computer system in the hospital, admission and discharge diagnosis,
okay,
including both the primary diagnosis and up to 15 comorbidities, medical conditions.
Only 15? That's like nothing.
Yeah. Number of medications prescribed at discharge.
Not type?
Number.
Yeah, just number, not any consideration of type.
There are some consideration of type, but since it needs to be, for the research, they needed to have like the number.
But different types of medications could have vastly different effects on someone's ability to remember things.
Yes, but to that we'll go later about
limitations.
Yeah.
All right.
Not only limitations, but it's going to be more in the discharge diagnosis.
Oh, okay.
Because people that just came with a heart attack usually have not the same medication, but medications that are very closely in the same family.
I see. Okay.
Okay.
All right.
The number of medication indicates on polypharmacy that, as you know...
Well, one definition of polypharmacy.
We already talked about it. I think that the other one should be mispharmacy.
That sounds like...
Or malpharmacy.
Yeah.
But we already talked about it.
See back to that episode for more details.
And hospital readmissions were also taken into account.
Over how much time?
In that year, but it's only into the UMMC.
Oh, so if they went to another hospital, they
didn't
wouldn't
know.
Okay.
Yeah.
Makes sense. So, okay, wait, let me just make sure I understand. The things that they looked at baseline were things like cognition with the MMSE, ADL function with the CATS, social isolation something with one that I don't know, and then the geriatric depression scale one. And that was it. And then like just an interview.
Yeah,
with
demographic, depression, disability, and cognitive and social isolation.
Nice. Okay.
And the other things are just things from the computer, like the diagnosis and everything. Now, this is something important.
Oh, it wasn't important until now.
It was.
Oh, okay.
But it's one of my criticism about this study.
Okay.
At UMMC, a nurse or a doctor explained the written discharge instruction to the patient prior to the hospital discharge. And the patient had an opportunity to ask questions and then sign a copy of a written discharge instruction, which is great because you see that they signed it.
Yeah.
And it's not like they nodded, yeah, I understand.
Yeah.
They nodded and signed.
Well, it's some CYA right there.
Yeah. And they gave them a copy and saved a copy. And if a patient went to a SNF, they sent the instruction to the SNF.
Yeah.
In this study, they defined patient receipt of discharge instruction by the presence of signed discharge instructions.
In which the copy of that is in the medical records. They can just look and say, oh, they got a copy of this. Here's the signed copy.
Exactly.
Okay.
Which is important because in other studies, they did not say that this is how they check that they got instructions.
Yeah, where they just kind of like, good job. Everyone gets it. Bye.
Right before the patient left with packing his stuff and all like, oh, you should follow up with the doctor and like,
make an appointment.
It's a signed one and everything is fine. And they created disease categories based on patient discharge diagnosis.
Wait, not admitting diagnosis?
No, discharge diagnosis. Think about how different it is whether someone was admitted for a headache, but, it was a tumor.
Got it. All right. Thank you.
They created disease categories based on patient discharge diagnosis and based on the ICD-9 codes. Categories were cancer, heart disease, disease of digestive system, disease of musculoskeletal system, and complication of surgical and medical care. The remaining diagnoses were grouped as other. Ready to see how they measured 5 days post-discharge?
Well, they measured with the phone call, right?
Yeah. But what did they say in the phone call?
I would assume that they asked, what were you told? Have you followed up? Repeat to me what you were instructed to do.
It's kind of like that, but it was done based on 4 domains. Okay?
They're always domains.
It's really important. It's because if I ask you a really general question of like, what did the doctor say? What did they say about exercise? What did they say about medication? What did they say about symptoms?
That's a good point.
So 5 days after discharge, follow-up calls were conducted by a single interviewer that was trained. They used the written discharge instructions form from the records as the gold standard.
Yeah, I was right.
Yeah, you were. But in general, there are kind of 6 domains that you try to give patients instructions about when they discharge from a hospital.
Okay.
It is medications, follow-up appointments, diet, and exercise. Those are the ones that were included in the article.
Those are medications, appointments, diet, and exercise?
Yeah.
Okay.
But also you give them an instruction about weight and worsening symptoms. Like,
oh, yeah. I've seen that in a lot of discharge summaries. Like, patient was instructed to come back if they experience X, Y, and Z.
Exactly.
Yeah.
So they did not include that in the weight and worsening symptoms in the follow-up questions 5 days after, because they are conditional on changes in status that may not have occurred during this study period.
Oh, yeah, because if it had happened to them... It takes you more than
5 days to gain weight. The medication, follow-up appointments, diet, and exercise are things that you're responsible for now.
Yeah.
So we need to see if you're compliant with it now or not.
That makes sense. Good work, researchers.
I'm not going to go over all the questions they asked. I just wanted, because exercise is important for us.
Truth.
Exercise comprehension was assessed by asking if a patient was told to engage in any physical activity at hospital discharge. And they were prompted by saying, were you told to go to physical therapy or walking? Like, they prompt a little bit if they didn't answer. Because tell someone physical activity, sometimes they would say no, but then, did they tell you to go to physical therapy? I'm like, yeah, of course. They documented the response of yes or no. All right, characteristic of the study participants. The mean age was 72.5, standard deviation of 6.1. And the most prevalent discharge diagnosis was...
Heart disease.
Heart disease.
Let me tell you.
Who received discharge instructions. So 100% of participants were prescribed medications at discharge.
Yeah.
New or continued.
Oh, yeah. Medicine.
Yeah, pop that, Lipitor. 99% were told to follow up with a hospital, clinic, or private physician. 58 received diet instructions, and only 19% received exercise instructions.
What?
Yes.
What?
Yes.
19%. Oh, gee. And it's all heart. I mean, the majority is heart.
Yeah,
blah,
22
blah, blah,
were heart. There were musculoskeletal. There were, So only 19% of all the participants got instructions for exercise.
You know, I love the articles you bring, but man, they make me angry. Like I can feel my heart rate increasing and my blood pressure rising.
You shouldn't exercise.
Have some fries. God, that's horrible. I had no idea.
Yeah. Discharge diagnosis was associated with the receipt of discharge instruction concerning diet and exercise. So if you were there for heart disease, you were most likely to receive diet instructions.
Yeah.
Like 91% of the people that were discharged with the heart disease diagnosis got instruction about diet.
How many got exercise instruction?
Out of the heart?
Yeah.
I remember it made me really sad. I think it was like 12. Erinn was not close to the microphone at all, and still you can hear her screaming.
My neighbors can hear me screaming.
Yeah.
Sorry, neighbors.
Do you want to guess which diagnosis got the least instruction when it comes to exercise and diet?
If it was musculoskeletal, I'm going to cry.
No, it was cancer.
Oh.
Because you can eat whatever now.
Yeah, just enjoy.
just enjoy now.
Although oncology physical therapists would disagree.
I know. But I have to say that when my uncle died from liver cancer, and his daughter was really strict all his life about what he should eat. And in the last 8 months, when they knew it's going to be over.
It was terminal.
It was you can eat fries at 5 a.m.
I would.
So patients with discharge diagnosis of cancer were least likely to get instructions about either exercise or diet, which is a little wrong. Can send them to someone.
Yeah, and think about quality of life.
Yeah.
What percentage of them received diet and exercise instruction?
Actually, about diet in cancer was 41%.
Oh, that's pretty good.
Yeah, and 8% got instructions about exercise. But patients with discharge diagnosis of musculoskeletal disease were most likely to receive exercise instruction.
Yeah.
Only 67% though.
What?
I want to believe that they didn't give them exercise instruction, but say, hey, you should follow up with the doctor or you should follow up with the physical therapist.
Yeah.
So it would be more in the follow-up instructions and not the exercise instruction.
Well, sounds like you're optimistic,
I
but
am
I'm not.
very optimistic.
I'm not at all. Definitely not.
Do you want to talk about the results of non-comprehension?
I mean, will it depress me?
Probably, but life depresses.
Let's do it!
Yes. So 5 days post-discharge. Non-comprehension of discharge instruction was 5% for follow-up appointments, 27% for medications, 48% for exercise.
Not only are they not told anything, the ones that are told don't even f***ing understand.
But to be fair, and 50% for diet recommendation. But
Same.
I have to say, remember that I said who gave the instructions?
Doctors and nurses.
Yes. Why wouldn't a physical therapist come and give you the instructions?
Or a dietitian for the diet.
Yeah.
That would make a lot more sense. And honestly, doctors and nurses in hospitals are running around like crazy.
Yeah. Exactly.
They're not going to have time to make sure that the patient really fully understands the instructions. They're going to breeze over. They're going to be like, you got that? The patient's going to say yeah and sign it, and then they're going to go to the next patient.
Exactly.
At least, that is what I assume happens, because as someone who is not a nurse or a doctor, that is, like, I can't truly speak to their experience, but that is my guess.
No, but they're overworked. Definitely.
Absolutely.
Yeah.
Wow.
So, can I move on?
I don't know. Will it depress me?
Probably.
Because,
no, it probably wouldn't. You know what? This part is not going to depress you.
Oh, thanks, dear.
Also, I crushed some Xanax into your...
I feel so much better.
Because heart disease was the most common discharge diagnosis, they used that as the comparison to some other for a regression analysis. Increased age was significantly associated with non-comprehension of medication instructions.
Oh, yeah, okay.
Okay. Also, another factor that were associated with non-comprehension of medication instructions were people that the discharge diagnosis of them were complication of medical care.
I see. So, like, the sicker people.
Yeah, and other.
Oh, yeah, stuff that we couldn't fit anywhere.
Another thing, increased age was also associated with non-comprehension of follow-up appointment instructions. So two very critical things we somehow do not explain well to people that are older.
Yeah. Oh.
Okay. But
you said this wasn't going to be depressing.
Because about exercise, it made no significance. They understood that that's just the same. The diagnosis of other and complication of medical care was also significantly associated with non-comprehension of follow-up appointments instructions.
Makes sense.
Male sex was associated with non-comprehension of diet instructions.
Interesting.
Social isolation was significantly associated with non-comprehension of exercise instructions.
Why? Did they hypothesize?
There is the hypothesis. Remember that we said that isolation and loneliness makes some parts of your brain that has to do with interaction with other people a little bit less functional?
Yeah, I remember that conversation.
So I think it's that.
Well, but what does that have to do with remembering things about exercise? Because you can do exercise as a solo activity.
Yeah, but somebody explained it to you, and probably as someone was explaining it to you, you're like, yeah, go away.
That's a really good point. That's very interesting.
Thank you.
Loneliness, tying in. Love it.
So that was about non-comprehension.
Okay,
so we had a lot of people that did not comprehend.
Bummer.
About non-compliance, 5 days post-discharge. So they examined non-compliance with discharge instructions among those who understood the instructions.
So these are the people that got it and decided against it.
Exactly.
I have some patients like that right now.
Yeah, I see what you're saying, but
yeah, like
330 people that understood the instructions about medications, 423 people that understood follow-up appointments, 129 for diet, and only 45 for exercise.
Stop it. That's out of the 700 plus people, only 45 understood.
Only 45 got instructions were only 19%.
Oh.
And out of that, yeah. So out of that, only 48 understood.
All right. So as this makes me angry, I realize this is a place that actually could be an opportunity. Like,
I love how you call me an optimistic, but then you're like in such a denial that like, oh, I can make this better.
I can fix this. Well, no, if you think about it, like we can present this information to the powers that be in our respective hospitals and say, look, we know exercise helps this plethora of things and can make our outcomes awesome. However, our patients aren't understanding the exercise education that they're getting. Why don't we have rehab come in and educate the patients before they're discharged?
That's true. I'm just sorry. I'm preoccupied with you being so disappointed at what I'm going to say.
Oh, no. Oh, here we go.
About the non-compliance.
Here we go.
So non-compliance. Do you want to guess or do you want me to tell you things?
Just lay it on me. Just go.
10% for medications.
Compliance?
Yeah. No, non-compliance.
Oh, I'm sorry. Non-compliance.
So 90% compliance.
Okay, good job.
0.2 about follow-up appointments.
What?
Which is boss.
Oh, wait. I keep forgetting it's not.
Non-compliant. Okay. Do you want me to say compliance?
No. We're good.
I can do that
0.2 is great. No, I can't.
It's great. 20% for diet.
That's better than I was expecting.
Do you want to guess about exercise?
90.
Non-compliance?
Yeah.
Wow, you're really putting a low raft just so you will be happy.
My expectations are low.
51% for exercise instruction.
Actively choosing against it. Understanding. And then saying, no.
Do you want to hear about, like...
I don't know, do I?
Do you want to hear about factors that were associated with non-compliance?
Absolutely. I think that's important.
Yes. So...
You really rained on my parade.
I know, it's a hot day.
It is. It is a warm day in New York City.
Also, everyone. I love that song. So, one or more ADL disabilities and self-reported history of diagnosed depression were significantly associated with non-compliance with medication instructions.
Why?
Because when people are depressed...
They don't want to do anything.
Already, it's hard for them to do ADL. Am I gonna, get up and take my medication? Self-reported history of depression was also associated with non-compliance with diet.
So you're not going to make any dietary changes.
Yeah.
Or you're much less likely to make them and stick with them.
Yeah. And it's a little sad they couldn't find something that is significantly associated with non-compliance to exercise.
Really? Nothing was...
No, depression was, but it wasn't significantly. They found
there's
a correlation, but they couldn't prove statistical significance.
Man, I wish they had taken more data at baseline. Like about beliefs about exercise, experience with exercise, or like education levels or socioeconomic status. Or did they? And I just don't know.
They did. It's part of
and nothing else correlated.
Yeah, that's all I have to say today. But I want
to... That's it. Bye.
But no, I want to say that I chose this article although I knew it would make Erinn sad, and I try not to make Erinn sad.
It's difficult. I'm disappointed by many things.
Yeah, I know.
Every morning Tali wakes up. Today, Erinn won't be disappointed in me. And every evening, Tali goes to bed. Maybe tomorrow. I'm teasing.
So I chose this article, although it's a little depressing, because I think it's really important for us PTs to know that when we give instructions home, they might not do them, and we need to see why. If not, why waste our time and paper?
Poor trees.
On things that people are not going to do. So, yes, I do think it's important that the nurse and doctor are not the ones to explain about exercise.
Yeah, I agree. I was serious.
It is good to have them also say, yeah, you should really exercise, or you should listen to the physical therapist that gave you an exercise program.
Yes. I was serious when I said, this, as depressing as this article is, it can present an opportunity if someone wanted to take on that responsibility in their setting.
Yeah.
You can make very tangible change and truly, save your hospital money by making the outcomes better.
That's all I have to say for today. I'm not depressed about that.
That was a rockin' article.
Thank you.
I really liked it a lot. It taught me something new, and it gave me ideas about what I can do moving forward. And now I know people aren't going to listen.
No, it's just that you need to do an extra step in order for people to listen.
Yeah. Or, honestly, it sounds like we need to do the baseline education, because often the education doesn't even happen. So.
Yeah. And I want to say that this article was done 5 years ago.
Yeah, it's probably worse. Everything's worse.
No, it's not because it's worse. Now we have other methods. We have more YouTube videos, and we do keep in mind that people are different learners and have different learning styles.
That's a good point.
Yeah, that's all I have to say about that, though. Erinn, do you have anything?
No, just I mean, I think, like I said, it presents an opportunity. And I think that people can take this article, which a link to the article, or at least the abstract, will be in the show notes, so that you with institutional access can find it, read it, use it to build programs, educational programs, and to make your outcomes and the hospital's outcomes better, and to make your patients even better.
Cool. All right.
Thanks, Tali.
No problem. Well, I'm Tali Spaceman.
I'm Erinn Carey.
And this is SRP Rex. And as always, stay funky.
Hit me. Thank you for listening to the Senior Rehab Podcast. If you only listen to these podcast episodes, you are missing out on 90% of the Senior Rehab Project. Hop on over to seniorrehabproject.com, where you can join the movement that's advancing care for older adults. You can join for free or become a part of the Game Changers, where you can get some free gear and access to our monthly meetup. Just go to seniorrehabproject.com. I appreciate y'all, and I'll talk with you soon. But in the meantime, do not forget to stay funky.